Our next session will be moderated by Dr. Peter Norton. He'll be talking to Dr. Finlay Sutton in the United Kingdom, and afterwards he'll be taking your questions via the session chat facility. Here's Dr. Peter Norton.
It became clear at the Australian Dental Congress in 2019 in Adelaide that our next speaker was a crowd favourite. Joining us today to discuss the integration of implant retained prostheses, it's a great pleasure to welcome to this 2021 World Dental Congress, Dr. Finlay Sutton.
That's great, thank you. Thanks very, very much indeed. It's absolutely fantastic to be here, Peter, and that was lovely. Great introduction. It was absolutely superb being in Adelaide. So I'm going to be talking today about using dental implants within dentures, but I just want to take you back to quite a number of years ago when I was doing a specialist training program at Liverpool Dental Hospital, and I did this most horrible clinic. It was the worst clinic I've sort of ever done, I think, and that was over this 6-year period. And it was the implant review clinic, and it was a total nightmare because on that clinic we saw all of the, or as many as possible, of the dental implant patients that had been treated ever since implants had been started being used in Liverpool. So it meant I saw tons and tons of problems. And I was just really left on this clinic on my own to get on with it. And so I really had to learn on the job. And this has been a tremendous experience for me with having a referral practice where I get sent to me patients who've had implants placed, and then there's problems with those associated with it. And what I did on this implant clinic, I really wanted to get things much more simple. So I'd see a patient like this that's got a bar and a clip. And at the time, this was back in 2001, Locators had just come in, the Zest anchor locators had just come in. And so what I did was I set about changing and simplifying all of these sort of more complicated over-denture type things. I used the locator attachments, and I found them great, actually. So I'd take off the bar, put simple locators on, and then the dentures themselves would be quite straightforward, and just changing from the clips to the locators. And I found that there was less maintenance with that. If you look in the literature, there are discussions between whether locators or bars are more maintenance heavy. But in my experience, I find that locators have less maintenance issues. So, and over the years, we've got different types of locator type attachments. So we've got Locator Legacy, we've got Locator RTX who's just come on, there's Nova Lock, CM Lock and Curator, and there's lots of other ones. And the great thing about these are the workhorse of the things that I use in practice. We've got the actual attachment is small in terms of height, so it doesn't intrude much or too far into the denture, meaning that we can position the teeth exactly where we want them to go more easily, that is. So I just want to share with you this first case. I want to really just be really clinical on this talk. This is Lynn here, and these are the remaining teeth that she had, which were just not restorable, got caries and perio. And she's got upper and lower partial dentures, which are just not fitting particularly well either. And also Lynn's had various concerns about her teeth. So she had bad fitting dentures. She was really conscious about smiling. She covered up her mouth, when she was at work and when she was laughing, and she sort of hid away in the background in her work because she just felt embarrassed about this, and she was worried about getting married, etc. And she wanted a life without crooked teeth. She wanted to be able to smile and socialize with confidence. So this was the after discussing what she wanted, she in terms of like dentures, implants, fixed restorations, etc., she plumped for implant-supported overdentures. And I use the ITI system in terms of numbers of implants for dentures. So for an upper and lower overdenture in the maxilla, because the bone quality is not as good, I like to use 4 implants. And in the mandible, 2 implants, because we've got really good solid bone at the bottom there. And this is the sequence of treatment for Lynn. So we've got, we do the immediate implants, immediate denture placement and implant placement together. This is all in one. So extract the teeth, fit the implants, and place the dentures. And I don't connect the implants to the dentures just at that time. I connect the implants to the immediate temporary dentures at 3 months' time. And then add the, make some new dentures and connect those to the implants at a minimum 9 months after extracting the teeth there. So my talk today is just about providing the implants overdentures. It's not really about the planning aspect of the placement of the implants, but I do want to have the implants placed lingually or palatally compared to where the teeth are going to go in the denture itself. So whenever the surgeon's placing the implants, I'm always encouraging them to get them more lingual, to give my dental technician, Rowan, more space. So 3 months later, after I place the locator abutments. And if you look in the maxilla here for Lynn here, the implants have been placed really nicely palatally positioned compared to our position of the drilling guide. And this is the position of where the teeth are on the denture. So they're placed palatally, which then means we can then have the housing and all of the stuff that goes over the top of the locator, not interfering with the tooth position. So at 3 months here, I connect the implants, the dentures to the implants there. And then the patient now is on a lovely, stable position for the next 9 months. So let's fast forward now, 9 months later for Lynn, and we're now ready to make our lovely, final, definitive dentures here. So I put on the, I'm ready to now do my definitive, my working impressions. So I put on my impression pickups onto the implants, onto the locator attachments. And then I do a working impression of that. And I don't throw out all of my really good prosthodontic principles. I want that lower complete denture to be extended beautifully and to be border molded really well, so that these implants are just helping to retain the denture, but we've got great stability, we've got great support from our saddle areas. So I like to use green stick to do the border molding of these areas, get the patient to perform different movements, and then do a working impression in Impregum like this. And during this process of doing the working impression, I get the patient to do exactly the same movements as I would do for a conventional complete denture. So it's E and ooh and licking the lip, pushing against the lower front teeth and having a really powerful swallow. And it produces a beautifully border molded impression, and the denture itself that's going to be made from this will stay beautifully stable. So same with the upper, just the same type of approach as if I was doing a complete denture at the top, but rather than using alginate for the impression, I use Impregum here. Now I want to just chat a little bit about shapes of dentures here. And I like to, if I'm doing a locator supported upper denture where the implants are not splintered, then I go for a complete upper denture, which has the normal extension of a complete denture here. This is to help to brace the implants underneath here. And this is the ITI guidelines also recommend this too. And the reason I recommend this is that I've made dentures with horseshoes, which are locator supported like this. But I find that I think the implants get stressed and loaded more in these types of patients, and the bone quality in the maxilla is just not great. It's not really that solid. So like in this case here, this chap, Paul, he lost his implant there, and had this implant that just was failed here. And when that happened, he's got this horseshoe-shaped denture, which is really redundant now. There's no suction on that. He needs fixative to help hold it in place. Whereas if I'd have made him the fully extended denture there, then it would be okay losing further implants down the line because he's got a fully extended denture with maximum peripheral seal on that to help hold it in place. And this is what I've got to always think about with implants, is planning for failure, because sometimes implants do fail. I want to nip back. This is back to Lynn now, and I'm just going through the normal process of making her upper denture now, which is implant supported. So using this smile of the natural teeth, that gives us an idea of where we want to place the teeth. And then we can go to a wax try-in of those. And I really love making dentures look as natural as possible. We've got recession in there. This is the finished denture. We've got gaps. We've got natural looking gums. And I use these superb Shotlander Enigma Life teeth. This is what I've been using since 2014 when they came out. And I think that these Shotlander Enigma Life teeth are some of the most lifelike prosthetic teeth that you'll get anywhere in the world. And if you're based in Australia, they are available from Ultimate Dental Supplies, who are sponsoring this event at the moment. You'll be able to look at them on the virtual showcase there and just have a look them up. Jim's the person that would supply them in Australia for you. So once I've made the dentures and finished them, I don't attach the final dentures to the implant straight away. I like to fit, if at all possible, and if I can persuade the patient to do this, to wear them first without them attaching to the implants, so that they sink into the soft tissues a little bit and get maximum support from the saddles and the denture bearing area before these are attached to the implants. But let's have a look at Lynn here with the denture in place. So she's got her full lower in place. This is not attached to any of the implants, and I'm just gonna lift this out here, and I've got good suction on it here. So that's without it attached to the implants yet, but I let Lynn wear that lower denture for approximately 2 to 3 weeks until it's totally comfortable, and then we're ready to attach the denture to the housings. And the way that I do this is I fit the housings onto the dental implants. These are the locator housings. These are going to fit inside the denture itself. I make sure I put this little PTFE washer on underneath. I've sandblasted these housings as well, sandblasting them out of the mouth. And this is a really neat little sandblaster by Cavo called the Rondaflex, which is quite useful for this sort of thing. And then what I do is I make sure that the inside of the denture is not touching those housings. And I use my occlusal spray. This is the stuff I use loads of in removable prosthetics. And this I spray that onto the fitting surface of the denture and try it in. And if it rubs off onto the housing there, then I know that the denture is not quite sitting properly in the mouth. But once I'm happy with that, I then add in, this is UV Gel Hard, which is a composite material, a pink composite. And I put in some of the composite material into the hole where the housing is going to fit. I don't put too much in. And I don't actually do them vented either. I don't put a hole through the back of the denture. It's just nice, decent sized holes with undercut on. And then I take this to the mouth here and I place pressure onto the premolars so that the denture just sits down really nicely. Do you know what? I don't chance the patient biting together at this point. So I just do it with my fingers, press it down nice and firmly so it's seated back down. If I get the patient to bite, I don't know what position they're going to bite in, and they may tip the denture and then we set it at an angle. So I just do it with my fingers here. And then I take that out and I change out the housings, the lab housings for the actual attachment inside there. And I go for the attachments that I like to use are the weakest possible. So either a blue or a red. And occasionally I'll use a green if I've got a grey if I've got multiple attachments. This has got 0 retention. We've got 500 grams, 1000 and 1500. And this silver thing at the bottom here is quite a neat little locator tool, core tool, where you can take the attachment out and replace them. So here we've got Lynn, and we've changed her life with the new denture there. It's fantastic. And it really did transform her life. And these sorts of attachments really, really do help the dentures to fit beautifully. And I think really spares are really useful. So we've got our immediate, our temporary set here, which you've got the attachments on. And then we've got our Mark II set just here. I do want to just show you what happens with locators in the lower though. If we've got 2 implants in the anterior mandible, at the front of the mandible there's always some degree of rock on the denture. So watch this video now and me tipping Lynn's denture here. Can you see that? Just tipping. It still retains superbly, but there is pivot at the front. And that's purely because the denture is held in anteriorly. So whenever I'm doing this for a patient, I just warn them about the denture is going to be retained really well, but there'll be a little bit of rock on it, just because of the mechanical engineering principles of this situation. Now, you'll have probably noticed that these final set of dentures, the definitive dentures, had a metal cage reinforcement within the dentures, and this is the shape of the metal cage that we used for Lynn's lower denture. And if we look at the cross section of that, it's T-shaped. It's really solid. It doesn't allow flexing of the denture, because these things do get hammered. You know, once these dentures are fitted to implants, the patients can really, really chew well with them, so they do break. Quite often, I find that the cage, it's not possible to do because the thickness of the denture has to be quite thin anteriorly here. In those circumstances, I reinforce them with metal. So I absolutely do not make any final dentures without a metal reinforcement within, just because of the breakages that happen. You know, if a denture breaks, the patient really does lose the confidence in the prosthesis. Even though it's quite straightforward to fix, they do lose confidence in their denture. So the plates are designed in a specific way. We've got these little the plate comes across there, but right over where we've got the implants here, in this case there's 3, there's a little piece of metal that sticks over the top to prevent that locator from getting pushed out, the housing from being pushed out. If we go to the upper and the dentures are implant supported, then I use a plate in these circumstances. So if we've got anterior implants and the patient really hammers that denture, then I bring the metalwork over the top too. Now, let's move on a little bit. This is what Rowan says to me with the dentures, particularly when there's implants involved. He says, within the denture, he says, I need more space to get all of the components underneath the denture. And this is Anne here, and she's got a full upper denture. She's a combination syndrome. But I just want you to now just imagine if Anne had a locator attachment, an implant here at the back, further posteriorly. And often we find that the tuberosity enlarges and drops down, so it gives very little space available for implant components within the denture. And this is a really, really important point to get great aesthetics. And I know that dentists that are listening to this that do a lot of implant work will know that space is really limited in the posterior maxilla for the implant componentry to give the patient a really good smile. And often the posterior teeth have to be dropped further down, and it gives the patient too much teeth on show there. So this is something really, really important in planning. So I want to show you, just move on to case 2 now. This is a reverse combination syndrome patient. She's got upper teeth and a partial denture, upper natural teeth and a partial, and a full lower. And this is how she presented to me. Most of my cases now, into my implant cases that I do in practice, are ones that have had implants done in the past, and they need renewal of the dentures or stuff or rectification of work. You can see these ugly clasps on this upper denture. She's got a full lower, but let's examine the full lower that's supported by implants. And what often I find is that the dentures themselves are poorly extended. And what I really want you to sort of get out of this presentation is that the implants are just helping the dentures to stay in place, and that it's important to I try to make all of my complete dentures that are supported by implants fully extended up the retromolar paths, just as if they were complete dentures without implants. But look closely at these attachments here. They've been mashed up here. That male section just does not fit in there. And the reason is that quite often food and, strawberry seeds, raspberry seeds get rammed into the top of these here. And then the actual attachment just does not work anymore. So in these circumstances, I clean out the head of the locator and I just put a temporary filling in, like Voco clip in there. Just put that Voco clip in, light cure it, and there's no hole in the top. And then I change out the attachment from a pink to a green like that. So in other words, there's no male portion in the middle. It's just a female component, just fits over the top of the locator now. And it just means that if the patient struggles with the oral hygiene, then that is, these still work really well. But I did change this for this patient here, for Miriam, this patient. I changed it to a new denture completely, and it just shows the difference in extension of a beautifully extended denture compared to one that's not. And they just work so much better. It's really, really good. So we've got and then we changed out the old RPD to a new one too at the top there. And the upper's got these little dental D clasps. This is a conventional partial against the lower complete denture, and she's good to go. Now, one implant as well in some of these elderly patients, like this lady here, who's well into her 90s, just got one implant remaining. One implant's better than nothing, particularly if the denture is really well extended, optimally extended, just like I talked about in my complete denture talk yesterday. And here is Ellen, she's knocking on 100 now, and that's her with her complete dentures in place. Superb. Also, I do see lots of patients who've had failed implants. And this chap here, Ken, he had an implant further forward that had failed, where he had a bridge that spanned that. So in these circumstances, and if we particularly have got missing teeth on the other side, what I like to do is just convert the implant, and this is a Dentsply Ankylos implant, just pop a locator on, and it means that we can just make a nice partial denture with a attachment on this side here and no clasp there, and then a conventional gold clasp on the other side with a beautifully extended dental bar on that. So with Ken here, we've got a freehand saddle on that side with no clasp. It avoids the need for a clasp. This is a crown on that tooth there. And then this is my freehand saddle partial denture. You can see how Rowan's made this denture with these long teeth. Just looks amazing, like these periodontally involved teeth. But there's no need for a clasp there. Works beautifully. That's great. So I just want to share with you my final case here this evening. I'm just upping the stakes now for sophistication for stuff. But here's Olive, and this is how Olive presented to me. She's a lady in her late 70s. She's got a full upper denture at the top, which is supported and retained by 6 dental implants. Now, she's one of these cases, and we're seeing them more and more, patients who've had multiple amounts of implant work done. So she'd originally had a load of implants done using, these are Friolet F2 implants. These are a Dentsply implant that we used quite a number of years ago in the hospitals here in the northwest of England, at Liverpool and Manchester. So she'd had a load of those done, and then a load of them had failed. And then she'd had some more work done. These are Dentsply Ankylos implants. So she presented to me like this. So these are the 6 Ankylos implants at the back there. And the denture is held in by these studs in place. She's part dentate in the lower. She's got lower premolars and then that lower molar at the back. And she's a real grinder. She Bruxis is Olive. She's worn this denture not for very long, and she's bust off some of the teeth here, and it's not retentive either. The Dentsply implants at the back were the ones that were retaining the denture. These 2 at the front did nothing. They were just sitting there. So that's the fitting surface of the denture that she has with these little attachments in there. And these were just getting worn the whole time, and she was grinding on it and losing retention on that, and those attachments just getting wider and not able to do their job. This is quite a number of years ago. This would be 2014 when I saw Olive. So this would be getting up towards 7 years ago. And so what I do in these circumstances, I want to look at what's going on with the implants. And I found that the posterior implants were really in quite good condition. The Dentsply Ankylos implants, so 6 posterior implants, were good. The Friolet implants are not in great condition, and I didn't want to use those. But what I wanted to know was what angle are these implants? And so I've put a little screwdriver onto the stud there. I've also tried in on this at the lower there, a fixture head impression, and you can see that these implants are at an angle like that. They're going in and they're fitting into the bone of the maxilla. And I knew that if I put locators on those, the locators are still going to stick out like that. at the time, we didn't have any sort of angle correction facilities, like we've got with Novalock, where we can just bring things in, 17 degrees or just to help make them more parallel. That was just not available. But my options for Olive really here were for either to do a full upper denture and not use them, just put them to sleep, or make a bar supported denture as a horseshoe. Because I just wasn't able to use the locators with all these angles. It just would be a disaster for the patient again. So we chatted about the two options, either a complete denture or a horseshoe shape. And Olive wanted to proceed with a horseshoe shaped denture. She did not want the palate covered by the denture. So that was an indication to go ahead with a bar and connect all of these upper implants together. So I did a working impression here. So getting all the fixture head copings on, linking those together. We've got a special tray with an open area there, linking all of these implants together like that. And then doing an impression in Imprigum. And that produces this, we produce a soft tissue model and on this here, ready for a bar to be made. Also do a wax rim at this point and go for a try-in, because I want to know exactly where the teeth are going to go before we get the bar and the sleeve and the overdenture made, so that the bar's made in the right position to be accommodated by those teeth. So here we've got the try-in sitting onto the working cast. This all goes over to Spain, actually, in Madrid, as to a firm called Createch, which is part of Straumann. And they produce a file like this, an STL file of the bar and the sleeve and the overdenture. And we can look at the space. I can examine how much space we've got for the denture itself, plus the housing that's going to fit inside the denture, plus the bar, which is that turquoise color in the middle. So once we've verified that, we get the bar made. So I've got the bar ready to be fitted, but I put universal abutments on these posterior implants, these Dentsply ankylos implants. And then I can then try in the bar. So here's the bar that we've got made for Olive there, with locator attachments on it. And then over the top of that bar is a sleeve that fits. This is a milled titanium sleeve that just fits over the top of the bar. And that sleeve is going to be incorporated within the denture itself. And that's milled to fit perfectly, both titanium. So the titanium sleeve then has the teeth fitted to it, and Rowan really skillfully adds the teeth on. And these are the Shotlander Enigma Life teeth on that there. The bar's been opaqued. And in these cases, I make two sleeves, two dentures for the patient, because the patient really wears these down quickly. So the patient will eventually wear one on a Monday, swap over to that on a Tuesday, Wednesday, Thursday, Friday. So they both wear at similar rates there. It's really, really important that. So once we're at this stage, I just want to verify that Olive is totally happy. And this is a try-in of the final overdenture in wax. So we've got the teeth set, and I just want you to make sure that she's 100% happy with the aesthetics. So she has a good look at this video, and we make sure she's totally happy with that. And then Rowan finishes the denture there like that. So we've got two identical dentures just like that with the Enigma Life teeth. And you can see here a cross section. This is the articulated cast with the bar in place. You can see the bar there, and you can see that if we were to do a fixed restoration for this patient, it's just not going to be possible when I superimpose the denture itself. You know, having a proper flange going all the way up here to support Olive's lip is really important. And that would not be possible in a fixed restoration and the patient to be able to clean under it. So if we look at the fitting surface of the denture, we've got a lovely sleeve there with the locator attachments in. And now we've got Olive with the upper overdenture fitted there. And the sleeve fitted in the mouth, so you can clean under it. And is Olive happy? Yeah, she's dead happy with that. But disaster struck. And this is familiar to people that do a lot of work with implants 4 years later. Implant failed. Let's have a look at it. That bar had fractured because an implant had failed here. And in doing so, it was loaded and stressed that bar, and the bar had snapped like this here. So it fractured the bar. So this restoration that cost the patient about £30,000, British pounds, is now redundant. So unfortunately, the only option for Olive at this point, she did not want to have more implants placed, was to make her a complete metal-based upper denture like that with an acrylic post-am. So I just put the implants to sleep, put covers on them, and then made a complete upper denture here with the occlusion as far back as possible on that denture there. So here we've got the complete upper denture biting on those lower teeth as far back posteriorly as possible. Here we've got Olive in the chair with the complete upper denture. I'm trying to pull that out. Got a great suction on it. Can really pull on that. There we go. And that's how she is just now. And with the complete upper denture in place, she's not as happy about it because it's not as well retained as the bar sleeve, but it's still usable for her. And so that was really quite a nice get out of jail thing. But I just wanted to share with you that failure there at the end, because this happens with implants all the time. So with these series of lectures, I'd really hope that you can think about the dentures a little bit differently. Maybe you can start doing them differently and implementing some of these techniques I've talked about today. And also think about potentially, if you early on in your career, just find a mentor, do some courses. I'd love to see you over in Britain at some stage when that's available too. So thank you very, very much indeed for listening. And there's loads of information on my website there. And if you want to email me any questions, please do so at the above. So thanks very much indeed.
Well, Finn, thank you for one more amazing presentation. I understand you've already presented twice at this Congress. So for anyone who has missed those presentations, they are or will be available on demand very shortly. A few questions to work through because you've stimulated a lot of interest, not surprisingly. With no disrespect to Rowan's amazing skill, have you ever considered printing or 3D milling dentures?
Yeah, not at this point, no. Just purely because of that. That's one of the main reasons is the aesthetics. Peter, we just get better, particularly, I think this is really importantly, the gum work, getting that lovely transition of different colours of the, gum material. But it's definitely watch this space. Printed dentures are a way, definitely something that we'll be able to do. And it'd be lovely to have an STL file which you can just print off a new denture when the patient breaks it or loses it, so yeah, watch this space.
Let's keep an eye on things. What is your preference for over-denture attachment systems? Firstly, if you have lots of space, and also if you don't have lots of space.
I think my preference is quite simple. Keep it as simple as possible. I love Locators because you know what? I don't think I can't remember the last time that Rowan said to me, "Oh, I've got plenty of space here for a bar." So it's just that if the attachment can be as low and as small as possible, then that is great. So the Locators, Novalock are really good. Most of my work is involved in not actually placing the implants. I've got lots of patients who've got old implant systems that I'm just using and restoring and replacing their dentures. So I just try and keep the attachments as low as possible. So I really don't do a lot of these bars at all, Peter. I just keep it as simple as possible.
We've all enjoyed seeing your techniques in previous lectures about sort of border molding and getting really good impressions. But when you are border molding and asking the patient to swallow, is there a risk of impression material being swallowed or inhaled?
That is a really good point. You know what? I really don't find it's a problem. It's not certainly not inhaled. And the border molding, the swallowing is done with the lower dent. It's for the lower impression, not the upper. I think the main thing is that I think about, and I've not had anyone swallow the impression material. I don't overload the tray. The special tray is really closely fitting, and so I don't put too much material in there. So it's just really not too much material, so it's not going to go everywhere. And true, it's just not. I do not find that a big problem, but it's something that naturally you'd think would be, but it isn't.
Great. How often do you need to replace locators?
So in terms of the attachment itself, the better the denture. If the denture is really well extended and it's well supported by the edentulous saddle areas, then the locator itself doesn't get loaded or stressed too much, and they can last a really long time, like 2 years, 18 months, 2 years. Generally, what I like to do is to see the patient on a yearly basis and replace them. Just get the patient in, examine the mouth and change them out. So ideally, I see them on a yearly basis, but sometimes it can be years before I see the patient. And they do last a long time, but it varies from patient to patient. Patients, some patients really do put they brooks on the dentures as well. So if they're really quite heavy on their teeth, then the attachments do wear out quicker. But certainly it's not any more than a year.
Why is the wear rate so great in a case like Olive on her implant supported dentures? And how long do you tell patients like Olive that their prosthesis, the over-denture prosthesis, is likely to last?
Good question. First of all, the implants are just unforgiving. They have no periodontal ligament at all. So they're ankylosed into solid bone. So there's no shock absorber at all. And also there's no feedback, or there is feedback, but it's just not the same sort of level of feedback. So patients can bite much harder without knowing that they're actually doing it. So if they have a tendency to brooks, and I think it's part of being a human being, is brooksing, they do this. So implant supported restorations, be it fixed or removable, get a load more hammer and stress than tooth supported restorations. So that's number one. And in number two, what do I say to the patient? How long is this restoration going to last? That is a really difficult one. It's really how long is a piece of string? And this is why I advise or like them to wear two lots, and where they have like one denture and the second, and they alternate them. So they both wear at the same rate, but when one catastrophically breaks, they've still got this spare that fits really well and is comfortable, and they can leave the the broken one with us, with Rowan or the technician, and can get that repaired at that technician's leisure, so they're not, on the spot having to get it done really fast.
I think it's excellent advice, and certainly I'm going to be considering that for my patients to manage catastrophic failures. Look, unfortunately, we're out of time. There's much more we could talk about, but look, you've been very generous with your time and your expertise, so thank you for speaking with us at this 2021 World Dental Congress. We look forward to welcoming you in person to Australia whenever we're allowed.
That's brilliant. Thank you so much, Peter. It's been a really great experience. Thank you.